All right, good morning. We're doing chapter 39. The concepts in this chapter are going to be sensory perception, which is the ability to receive and interpret sensory input into one or more meaningful responses. So therefore, we're talking about vision. This involves detecting and interpreting light through photoreceptors in the eyes, which allows us to perceive shape, color, and movement. So we get into the function. We're talking about refraction, which is the bending of light. From the outside, it moves through curved surfaces to the retina, the light does. You've got your hyperopia, which is your farsightedness. Distance vision is normal, but the near vision is poor. Myopia is nearsightedness, overbending of the light, and images converge in front of the retina. Then it talks about constriction and dilation, which control the amount of light that let into the eye. Accommodation is the process of maintaining a clear visual image when the gaze is shifted from a distance to a near object. And then convergence, the ability to turn both eyes inward toward the nose at the same time. And then it just shows you pupillary constriction. You need to know that the meiosis constricts when the light increases, and the mydriasis dilates the pupil when it becomes darker. So you remember that eye, because you'll see a lot of terms, miotics with an eye. You know it's constricting the pupil. If you see mydriotics with a Y is wider, so it's dilating the pupil. So don't forget those. And then it goes into the changes that are associated with the eye with aging. As you age, there's a decrease in the tone of the eye muscle. That's an expected age-related change in older adults. It puts them at risk for falls. The lens thickens, which also puts them at risk for falls. It loses its flexibility. They get a decrease in depth perception. There's a change also in color perception. It's harder to discriminate certain colors, such as blue, green, and violet. The intraocular pressure increases in older adults. So therefore, they're going to need more eye exams to check for possible conditions such as glaucoma and cataracts. Therefore, an eye exam is recommended every 1 to 2 years. So this picture shows what's called arcus sinalis. This is caused by fat deposits. It doesn't change vision, but it can be associated with high cholesterol, particularly in younger individuals. If the ring is only present in one eye, it's called unilateral arcus sinalis. It can indicate a problem with the coronary arteries, and it should be investigated. All right, so then they get into the health promotion and maintenance part of it, where they're trying to, what are our teachings to prevent eye disorders? Teach the patients to wear sunglasses to protect from UV rays. Wear eye and head protection when working with particulates, sparks, blood or fluid or objects in motion. Avoid rubbing the eyes to prevent trauma. Control your blood glucose and blood pressure. Make sure you're getting adequate vitamins, specifically vitamin A, which can lead to blindness or dry eyes. Make sure you're consuming adequate beta carotene. And then it gets into the eye drop technique. We got to understand the eye drop technique. Remember, it is a sterile procedure. When you're putting eye drops in someone's eyes, you're going to put them on their back or lying down with the head tilted. If they're laying in bed, you can position a pillow under the head. You're going to inspect the eye, check for any discharge or signs of installate or irritation. Take the dominant hand, rest it on the forehead, hold the dropper about 1 inch to 3/4 of an inch away. Take your non-dominant hand, pull down on the lower eyelid, and instill the drops directly to the conjunctival sac. Avoid the eyeball directly or the cornea, because the cornea is very sensitive. Make sure they don't blink, because they could push the eye drop out, and then either you or them are going to hold pressure to the inner canthus for 1 to 2 minutes to prevent systemic absorption. And if you have more than one type of eye drop to give, you're going to wait 5 minutes in between. And if you have an ointment and drops to give, you're going to give the drops first. Now, we move down to the assessment part. The age-related changes. Remember, there's occupational risk for eye traumas. We want to know what leisure activities they're doing. Do they wear protection, eye protection, and sunglasses? And do they have any type of health problems like diabetes and hypertension, or cataracts, glaucoma? Remember, diabetes can cause retinopathy. It can destroy the vessels in the eye. We want to know if they have any Lyme disease, sickle cell, or any kind of autoimmune disorder such as lupus. If they're taking meds, we want to know the name, the strength, the dose, and the time. Remember, antihistamines and decongestants can dry the eyes out. They can also increase the intraocular pressure. We also want to know if they're what other drugs they're taking because of the side effects. It can cause the eyes to itch, or a foreign body sensation, redness, tearing, photophobia. They may develop cataracts or glaucoma. Remember that a lot of eye disorders have a familial tendency, but you need to know any sudden or persistent loss of vision within 48 hours, eye trauma, foreign body in the eye, or any severe ocular pain is a medical emergency and needs to be assessed immediately to prevent blindness. All right, so when we're doing our physical assessment, the face should be symmetrical. The brows should be able to raise and lower. The eyelids should curl outward, ectropin, not inward, because that could cause a corneal abrasion. The eyelid should also cover the eyeball and be free from edema. The lid should close completely with the edges touching. Head tilting, squinting can indicate blurred vision. We need to assess for equal distance of the eyes from the nose. Do the eyeballs appear to be bulging from the sockets as in exophthalmos, or do they appear to be recessing as in ophthalmos? Either of these two could indicate a possible thyroid issue. Also check the eyebrows, the eyelashes. Is the hair equally distributed? Check the eyelids. Is there any drooping called ptosis or redness or lesions? For the external inspection, you want to check the eyelid, assess for symmetry, drooping, edema, and lesions. Also check the conjunctiva. Note the color. It should be pink, and look for signs of inflammation or infection. Check the sclera. Observe for any redness, swelling, or yellowing called icterus, which is a form of jaundice. And check the eyeballs. Check for symmetry, alignment, and signs of injury. Then we're going to do our pupillary assessment. We're going to assess the size and shape of the pupil. They should be round and equal in size. Then you can shine light in there and do the pupillary light reflex. You're going to assess for equal and prompt constriction in both pupils when the light is shined in one eye. If they both constrict briskly, that is normal. That happens immediately when light is shined into the eye. If it's sluggish, meaning it takes more than 1 second, we call that sluggish. Now, if it's non-reactive, meaning they don't constrict, we call that fixed. So remember, you're also assessing for accommodation. So you want to observe for pupillary constriction and convergence when the patient focuses on a near object. And then you're going to document PERLA. PERLA is an acronym for eye exams. It stands for pupils are equal, round, reactive to light, and accommodate. It describes the normal appearance and function of the pupil during an eye exam. It indicates they are the same size, they're round and constrict in response to light and when focusing on nearby objects. Also, for visual acuity, we can use the Snelling eye chart. This can check the function of cranial nerve number 2, which is optic. It can also check distance vision, and you're going to stand at 20 feet away, and you're going to read letters to get from larger to smaller, and whatever score you get indicates how well your vision is. So If you have 20/20, it means at a distance of 20 feet, which is the first number, you can see what most people can see at 20 feet. If it was 20/30, then that means you can see at 20 feet what most people can see at 30 feet. And if it was 20/10, you can see at 20 feet what most people need to see, go to 10 feet to see. So they're going to check that. Now, we can also check the near vision with the Jaeger chart at a distance of 14 inches. They'll have them read paragraphs of text, printed text. Also, we can check the visual fields for confrontation. Position the examiner facing the patient about 2 to 3 feet away. The patient is instructed to focus on the examiner's nose or eye. The examiner covers one of their own eyes and then uses their hand or finger to test different quadrants of the patient's visual field. The patient is asked to indicate when they see the examiner's finger or hand, and the examiner compares the patient's response to their own visual field. The process is repeated on both eyes. We also need to assess for what's called nystagmus, which is involuntary eye movements or limitations of eye movement. We can also check color vision with the Escherichia color plates. If you are communicating with a patient with a visual impairment, make sure you face them and don't cover your mouth. You want to be at eye level, be clear and descriptive. Ask for permission to touch and describe the procedure before performing it. Instead of pointing and saying over there, provide specific directional landmarks. You can use the door, or to say the door is to your right, how many steps away, or you can use the clock method when describing things, 12 o'clock, 3, 6, 9, etc. Okay. All right. All right, so then it talks about laboratory assessments. We can do cultures, swabs, and scrapings to diagnose infection or to obtain specimens before starting antibiotics. We could do an MRI, examine the orbits of the eye, the optic nerve, and evaluate for any ocular tumors. It can't be used, however, for foreign bodies because of the risk of metal with the MRI. We could do radioisotope scanning, examines for tumors and lesions. That would require informed consent. Sedation may be used, but must be able to lay still for 30 to 60 minutes. Then you got ultrasound, where we put a probe on the eye or on the eyelid with a gel, and that'll send sound waves that bounce off the eye's tissue. These echoes are converted into images that then can be displayed on the screen. There are two main types. You've got an A-scan ultrasound, which measures the eye's dimensions for lens implant calculations, and you got the B-scan, which provides a two-dimensional image of the eye structure. It's a quick procedure, painless, and it doesn't involve any radiation exposure. All right, so then we've got the slit lamp exam. This is a common procedure used by eye care specialists to examine the structures of the eye in detail. It involves using a specialized microscope and a bright light source called a slit lamp to view the eye in 3 dimensions. Corneal staining refers to the uptake of a dye like fluorescence, revealing areas of injury. You got tonometry, measures the pressure inside your eye, the intraocular pressure, so we can detect glaucoma with this test. Ophthalmoscopy is also known as fundoscopy. It's a procedure used to examine the back of the eye, including the retina, the optic disc, the choroid, and the blood vessels. Then you got fluorescence angiography. That involves injecting a fluorescent dye into the bloodstream and then taking pictures of the retina as the dye circulates. It helps doctors identify abnormalities in the retinal blood vessels, especially if they have diabetic retinopathy or macular degeneration or retinal detachment. It can help identify various retinal diseases, including age-related macular degeneration, retinitis pigmentosa, or diabetic retinopathy. Then you have the electroretinography. An electrode is placed on the cornea of the eye after numbing with eye drops, and the retina is stimulated with flashes of light. The electrical activity is generated by the retina in response to light, and this is recorded. The recorded electrical signals are known as waveforms, and you have A waves and B waves, and they're analyzed to assess the health and function of the retinal cells. And then you got the goinoscopy, an eye exam used to visualize the anterior chamber of the eye. So we can use this for glaucoma to see if the fluid is draining out properly. And you got the ocular coherence tomography, which is a non-invasive imaging technique used to create detailed cross-sectional images of the retina and other parts of the eye. It utilizes light waves to capture these images and provides a 3D view of the eye's internal structures. Okay. All right, so when you're measuring the IOP, this is the pressure exerted by the fluid, the aqueous humor, inside the eye. This fluid helps maintain the eye's shape and provides nutrients. It's measured in millimeters of mercury. Normal IOP is between 10 and 21 millimeters of mercury. Anything above 21 is considered elevated, and it's classified as ocular hypertension, and it increases the risk for glaucoma. All right, so it's just showing a picture here. It tells you again about cataracts. We've been talking about it. Lens opacity can be both eyes, progresses differently in each eye though. The cause, genetics, it lists here. It can be present at birth, develop at any time, most often age-related, can be caused by trauma or exposure. Then it goes into the health promotion and maintenance. They need to avoid that sun or UV light, wear sunglasses, wear eye and head protection. And if they are a smoker, they need to stop smoking. So you need to ask about visual changes. Any blurry vision, decreased color perception are early signs of cataracts. They may not be aware until they try to read or drive, and it'll really affect them at nighttime. All right, so then it talks about the interventions. It says pre-op, if they are going to have a procedure for this, we need to go ahead and get that informed consent, explain the procedure. This is done by the doctor. They can do a procedure called a phacoemulsification. This is a high-frequency sound wave that breaks up the lens, and then the lens is removed by suction and a new lens is replaced. They also have extracapsular cataract extraction. This is for more advanced cataracts. The whole lens is removed in one piece and sutures are required. It's a slower recovery and there's a higher risk for infection with this procedure. Now, the postoperative care. We need to prevent intraocular pressure. We also need to prevent infection, and we need to manage the pain. Mild itching is normal after the procedure. So is a bloodshot appearance and slight swelling. Educate the patient to wear sunglasses outside or in bright lights. And they need to report signs of infection like yellow-green drainage, floaters, flashes of light, lid swelling, bleeding, increase in tearing, photophobia, and teach them to manage the swelling. Use cool compresses and no aspirin because of the risk for bleeding. Avoid all activities that increase intraocular pressure. Bending over, sneezing, blowing their nose, coughing, straining, head hyperflexion, restrictive clothing, and sexual intercourse. We may even want to get them prescribed a stool softener to prevent the straining, and have them report any pain with nausea and vomiting. Okay. All right, so that's just the question. And then it talks about atropine. Atropine is an anticholinergic agent used to dilate those pupils. Just remember, it's a serious med. It opposes the parasympathetic response, and the effects of it can last for 7 to 12 days. They're going to have very blurred vision and photosensitivity, so they're going to need to wear those sunglasses. Okay, so then it gets into the types of glaucoma here. So it says glaucoma is a group of eye disorders and is broadly characterized as either open angle or closed angle. And both have both primary and secondary. So open angle primary, this is the most common type where the drainage angle of the eye is clogged. And this leads to a slow increase in eye pressure. Secondary open angle occurs when another eye condition or injury, like inflammation or certain meds like corticosteroids, cause increased eye pressure and optic nerve damage. There's also a normal tension glaucoma. This type occurs when optic nerve is damaged and vision loss happens despite normal or low eye pressure. Then you got the closed angle, the emergencies. Closed angle glaucoma is an emergency. So the primary occurs when the iris blocks the drainage angle, causing a sudden increase in eye pressure. Secondary closed glaucoma can be triggered by a dislocated lens or possibly a tumor. And then you've got the chronic angle and the acute angle. The acute angle is a sudden severe blockage of drainage, resulted in rapid increase in eye pressure, and that requires immediate attention. The chronic angle is a gradual blockage leading to slowly increasing eye pressure. You also have congenital glaucoma. That means you're born with it. And then you've got a neurovascular glaucoma, a secondary to diabetes or a vascular disease. You also have traumatic glaucoma caused by an eye injury, juvenile glaucoma, a form of glaucoma that develops in childhood or adolescence, pigmentary glaucoma, where the pigment granules clog the drainage channels, and then finally pseudo-exfoliated glaucoma. This is a secondary glaucoma associated with the buildup of flaky deposits on the eye. All right, so risk factors for glaucoma. Okay, age. The risk of glaucoma increases over the age of 40. Race and ethnicity. People of African American, Asian, and Hispanic descent are at higher risk for certain types of glaucoma. A family history of glaucoma, especially a first-degree relative, significantly elevates the risk. Certain medical conditions like diabetes, high blood pressure, heart disease, these are all associated with an increased risk of glaucoma. Also, eye injuries, severe eye trauma can lead to glaucoma. Medications, long-term use of steroids, refractive errors like nearsightedness or farsightedness, so the myopia and the hyperopia, they increase the risk for specific types of glaucoma. A thin cornea, individuals with thinner corneas can be susceptible to the condition as well. Okay, so then it just goes back into talking about what we already talked about, all the different types of glaucoma. We've talked about most of these tests here. Just showing you a couple pictures of the test. All right, so then we go down to the interventions for glaucoma. Medical and surgical management. Medications like miotics with the eye, because you want to keep the pupil constricted with glaucoma. A dilated pupil decreases the drainage of the aqueous humor. We're also going to give them analgesics for pain, put them on rest. We may have to do a surgical iridotomy or a laser trabeculoplasty or a corneal trifling. All these procedures to increase the outflow of the aqueous humor. The nurse encourages regular eye exams and treatments to prevent blindness. Remember that acute angle closure glaucoma is an emergency. The nurse refers the client for medical treatment immediately because vision can be permanently lost in 1 to 2 days. Severe pain requires analgesics. To promote the maximum effect from the analgesic drug therapy, it is essential to limit sensory stimulation, such as loud noise, activity, and movement. The nurse informs the physician immediately if the client states that the pain has worsened despite treatment. And mydriotics, those drugs that dilate the pupil. Mydriotics, drugs that dilate the pupil, can never be administered to a client with glaucoma. We need to know that. No mydriatics. Don't dilate the pupil. Okay, then you just have a question here. It talks about corneal abrasions now. Okay, a corneal abrasion is a scratch on the surface of the cornea, which is the clear part of the eye. It can be from a foreign object, contact lens trauma, or even fingernails. Symptoms, they're going to have pain, redness, tearing, light sensitivity, and a feeling of something in the eye. The treatment would be lubricating the eye using antibiotic eye drops, sometimes a patch. You also have a corneal ulcer. This is an open sore on the cornea, often caused by an infection. A bacteria, a virus, a fungi, or a parasite can lead to an ulcer, often after a corneal abrasion. So the patient will have severe pain, redness, blurry vision, discharge, and a sensitivity to light. Similar to abrasion, but potentially more intense. It is an emergency, though, because the cornea has no separate blood supply, and permanent vision loss or impairment develops rapidly. The treatment is aggressive with antibiotic, antiviral, antifungal eye drops, and in severe cases, they're going to need a corneal transplant. Then you've got the corneal infection, the keratitis. This is inflammation or infection of the cornea. There is a relationship to having an ulcer with this condition. Ulcers are often a localized manifestation of a corneal infection. The cause is similar to ulcers, infection of a bacterium, virus, fungi, or parasite. The treatment is going to be topical antimicrobials, and depending on the cause, other treatments like dilating drops or oral meds may be needed. Now, the key points. Prompt treatment of a corneal abrasion is vital to prevent infection and ulcer formation. Corneal ulcers are a serious condition that can lead to vision loss if not treated promptly, and contact lens wearers are at increased risk for both corneal abrasions and ulcers, especially if they sleep in their lenses. Okay? All right. It says degeneration of the corneal tissue can occur with trauma or be inherited. Post-cornea transplant care involves using prescribed eye drops, wearing eye protection, and following specific instructions to ensure proper healing and prevent complications. It's crucial to avoid rubbing or pressing on the eye and to return for regular follow-up appointments with the ophthalmologist. Now, when you're cleaning, clean gently. Use a clean tissue to gently blot away tears and any crusting on the eyelashes. You can moisten a cotton ball with saline solution to remove any crusting. Do not irrigate the eye. Avoid heavy lifting and strenuous activity, which includes driving, sports, sex, bending at the waist. Wear eye shield for the first month at night and whenever around small children, pets, or particulates. Lay on the non-operative side to reduce the intraocular pressure. Assess for possible graft rejection. It starts as inflammation near the graft edge and then moves toward the center, which will cause reduced vision. The cornea will become cloudy. They may lose their vision, have some eye pain, redness, purulent drainage, or ongoing leakage of this clear fluid from the graft site. But this is not tears. Okay? They will be photosensitive, have a sensitivity to light. It's treated with topical steroids, oral prednisone, IV methylprednisolone, or an immunosuppressant such as tacrolimus. Okay. All right, then it just talks about eye donation. Okay. Just remember to keep that head elevated at 30 degrees if they're an eye donor. Apply your antibiotic drops and close the eyelids and apply a small ice pack to prevent edema. Okay. All right, then you get into the retinal disorders. We're talking about macular degeneration here, also known as age-related macular degeneration. It is the leading cause of vision loss, particularly among those 50 and older. It primarily affects the macula. That is the central part of your retina, responsible for sharp, detailed central vision. So this leads to central vision loss. This makes tasks like reading, driving, and recognizing faces difficult. There's no cure for this, but the treatments can help slow the progression and help to preserve the vision. All right, so there are two types of acute macular degeneration. There's the dry and the wet. The dry is the most common type, characterized by the thinning of the macula and the buildup of this yellow deposit called drusen. The wet occurs when the abnormal blood vessels grow under the retina and they start leaking fluid and blood, and that leads to rapid vision loss. So the symptoms in the early stages, they often are asymptomatic. They may have problems like seeing in low light or blurred spots in the center of the vision. But the later symptoms, blurred or distorted central vision, straight lines appearing wavy or crooked, dark or empty spaces in the center of the vision, difficulty reading and watching TV, or even recognizing faces. The risk factors are going to be age, especially over 50, if they have a family history, smoking, if they're obese, this can increase the risk. It's more common in white individuals, and individuals with heart or blood vessel problems may be at higher risk as well. There's no cure. Currently, there's no cure for dry AMD, but treatments can help slow its progression. Treatment for wet AMD can be treated with an anti-VEGF injection, which helps slow or stop the growth of the abnormal blood vessels. Lifestyle changes is going to be the focus. If they're smoking, get them to quit. Maintain a healthy weight and blood pressure. Eat a diet rich in antioxidants and green leafy vegetables. They can take prescribed supplements. They're going to need visual aids like magnifiers and large print reading materials that can help manage the vision loss as well. Okay. All right, then it just goes into explaining the diet. Make sure you read through here and look at the foods that they recommend, especially the ones that are darkened. Could be something you need to know. All right, so then it talks about the retinal holes and tears. Okay, so a retinal hole, this is a small break in the retina, often caused by thinning or weakening of the retinal tissue over time. The tears are larger, jagged breaks in the retina, often caused by the vitreous gel, which is the clear gel-like substance in the eye pulling on the retina. They can do laser surgery or freezing called cryoprexy to seal the tear or the hole and prevent detachment. A retinal detachment is the separation of the retina from the epithelium that deprives the eye of oxygen and nutrients. So this is a medical emergency, and it'll require a surgical procedure such as a vitrectomy or a scleral buckling to reattach the retina and prevent permanent vision loss. So the risk factors are myopia, inflammation, cataracts, or having eye laser surgery. All right, then it talks about retinitis pigmentosa. It's a group of inherited eye diseases that causes a progressive decline in vision due to the degeneration of the photoreceptor cells in the retina. These cells are the rods and cones. They're essential for converting light into signals that the brain can interpret as vision. The hallmark is a gradual loss of night vision and peripheral vision, often progressing to tunnel vision and eventually central vision loss. There's no cure. Treatment focuses on managing and maximizing the remaining vision. All right, then it just goes over some terms that we've already covered, the myopia versus the hyperopia. Okay. And then we've got the eye trauma, also known as ocular trauma. Refers to any injury to the eye, including the eyelids, surrounding tissue, and the eye itself. These injuries can be caused by blunt or penetrating objects, chemical burns, thermal burns, or radiation. Blunt eye trauma is caused by a dull object striking the eye, which can cause bruising, swelling, and damage to the tissue. Penetrating, this involves a sharp object piercing the eye, leading to full thickness wound. Chemical eye trauma can burn the eye like cleaning products. So can thermal eye trauma and radiation. Remember, do not attempt to remove any object protruding from the eye. It may be holding the eye structure in place, and improper removal can cause structures to prolapse out of the eye. Listen, guys, it's thundering here, and I'm afraid if I continue into the next chapter that I'm going to get a power outage and lose everything I've recorded. So I'm going to end the first chapter here and then restart again for the second chapter.